This conference will now be recorded.
Okay, this is Rick Davis. It's the 1st of June, so I'm on duty and I'm going to be ably assisted by Len and Dr. John and anybody else who cares to help out. We are right now sponsored by Novartis, Foundation Medicine, and Blue Earth, all of whom we thank. And we're working on a couple of other people, and we'll see where we go with them. A couple of other companies, I really should say, and we'll see where we go with them. Right now, we have no new people, so that's good. And anybody who's coming after 5 I will get to you later and ask you if you need time, provided we have time at the end of the meeting. Well, we will have time at the end of the meeting, and I'll ask you, but it may be after our official close, which we rarely meet. We did last week. I don't know how Ben did that, but we did last week. All right, we're going to move straight into the questions because we got no new guys, which is really good, but it's not really good if I think about it. We do like to have new blood, but it'll do for now, and it'll give us plenty of time. I'm going to go through people as they came in. And excuse me looking away here, but I just want to pull up my notes so I can make direct notes. So the first gentleman who was on the list and getting his water bottle is our foamy gland man, Mr. C in Virginia. So you're up first and tell us what's on your mind.
It's just a report. I went through the Pluvicto 6 rounds, finished those, then had the PET scan last week, and got the report and the results in there. The Pluvicto seems to have made a difference. The lymph nodes that were lit up and down the torso did not, in general, did not light up this time, and they didn't. They were still enlarged, and this is in general, and there was no progression in the pulmonary nodes at all. So the worst you can say is I'm not as active as I was before. Metastasis seems to have been curtailed, not eliminated, but curtailed. That was the report from Dr. Allen today.
Are you happy with that report?
Relatively happy compared to everything else. I mean, it's not progressing. That's what I wanted. I didn't expect to be cured. So,
does anything light up? Do we see anything at all on this PSMA scan?
The report didn't just said they didn't light up. I haven't seen the scan itself this time. I just saw the radiologist's report, which
Okay.
As good as the previous one.
Well, sounds good to me. Sounds like it had an impact.
Yeah, that's the response I got from Dr. Allen. He was happy with it, and right now we're just for the next 3 months we're just back to simple Eligard and uh, watch out. And I have no other symptoms, so I'm happy.
So
The only problem I'm having right now is the prostate did not show up with light up, but it is enlarged, and so that's giving me a little bit of urine retention.
okay, are you talking to a urologist about that?
Yeah, I saw the urologist today too, and right now I'm on a Foley catheter,
Oh man.
and the bad part was suddenly I had a shutdown the same day I was getting the PET scan. So I've gone through 2 catheters and from 2 different ERs in a week. And now we're going to stay with this for a while.
Okay, and you're on Eligard alone, no secondary drug, correct?
Right. The Abby, I just, it did not work at all when I was on that. And
have you tried an androgen blocker like darolutamide or apalutamide?
no, I haven't.
Okay, so again, that's something to talk to. That's something to talk to Dr. Allen about. And the other thing is to ask him whether you could go on to Orgovix instead of the Eligard, because it's a kinder drug. So I would be talking to Alan about maybe we should try darolutamide and Orgovix, or maybe even darolutamide alone, and discuss that with him.
Okay, that's worth doing it. I also have get Dr. Markowski.
Okay, so he's another one you can talk to. Gary Peters, you have your hand up.
Richard, I was just going to ask what's happened to your PSA during the Pluvicto treatment.
Yeah, but
I haven't had PSA that's detectable for 4 years.
Right, Gary, that's not, it's foamy gland, and PSA is not a good marker. That's why I didn't ask him. So, the foamy gland does not really, it doesn't tell us anything. We have to scan and we have to do other things, but foamy gland doesn't really indicate. At the same time, it's really good that that Richard produces PSMA. That's really fortunate.
Yeah.
Okay, thanks.
Any other questions for Richard? So I have a question for all of you, which relates to this Novartis. I don't know whether it's going to be a sponsorship or a grant that we're requesting. I'm curious, first of all, how many of you, and just use the hand function and just tell me how many of you have been on Pluvicto, have had experience with Pluvicto or radioligand therapy of any sort for scanning? I know that I know we got Frank and Stan. Okay, 3 on the website. Now, how would you all feel, the 3 of you, if we were matching you with people who are about to start radioligand therapy? Would you be willing to talk to them?
Yeah.
Sure.
So I've got a sure, I've got a yes from Richard, a sure from Friedman, and I know Chambra will. I don't have to worry about Frank Chambra. He'll do it. And who was the sure? And Stan, would you?
Hey.
Are you okay? Yeah. All right. Because one of the things we're suggesting, and this is part of a improvement on our website overall, is that we can educate people about Pluvicto or radioligand therapies, because I'm not saying Pluvicto specifically deliberately, but we can educate them with sending them to other websites and giving them a glossary and then giving them this, that, the other. But we can do something more that no one else can do, which is we can actually say, we'll give you real world experience here, and we'll let you speak to people and talk to people who have done it before you. And I'm sitting here saying it because I kind of know my guys and I know how generous you are with your time. At the same time, I thought I'd probably better just ask and make sure that nobody says, not me, I'm out of here if you do that. So that's the background to the question. And thanks to the 3 of you. And I think most of our guys, if they've been through a treatment, are more than happy to talk to somebody who has not been through it before. All right. Mr. C, very pleased to hear of this progress. I wish you were a little more happier, but you will be in time. What can I say? I understand why not right now. And we do need to get those urinary issues resolved. So keep working on it.
Yeah. And hopefully,
yes,
that's the only thing I've got to worry about. The lymph nodes up the left side are the ones that were growing a year ago before Pluvicto, and they lit up very brightly, and then they're backed off. That's all good news. So
that's good news. Okay, Sam, tell me what's on your mind.
Sure. I wondered if anybody has had the unfortunate experience of having radiation and then months later a hole appearing in the prostate and the colon, such that the patient, this is not me, this is a very dear friend of mine who's just getting out of the hospital now, so that the person has wound up with a bag for fecal material and a catheter for urination. And as a result of the surgery on Wednesday, has been told that he'll be in that state for at least a couple of months when they'll take another look at the fistula that occurred secondary to the radiation that he had for his prostate cancer. So my question is, does anybody on the call have any awareness of or experience with kind of situation?
Couple of things. We do not usually take questions, third-party questions, because we have so many people here. We just can't do it, because then everybody can come in. But I can tell you, yes, I'm aware of other people that have had fistulas as a result of radiation treatment and hormone therapy. Doesn't happen that often. Had something relatively recently, but it's not a usual thing. It's not a usual account. Okay. But I'm sorry to do that, but we just have to do it. We can come back and talk some.
I understand.
If we've got time at the end, we can come back and unpack that a little bit further, Sam.
Sure.
All right, moving right along. Just making my notes here. And we've got Tony G in upstate New York.
Yep. Okay. An update of sorts here. I'm in my have just begun my 4th month on Orgovix and continue to tolerate pretty well with only a few minor hot flashes as side effects. So my big next step is to deciding when to start radiation, and the main determining factor there is that 8 months after surgery now, I'm still experiencing some urinary incontinence, even though it's improving. But my experience there has been that I go for many days thinking that I've normalized, and then I have a bad day with it. And so I've talked to 2 radiation oncologists, and one here in Syracuse and one at Wilmot, and they're telling me to, we will revisit the issue every 3 months, and if it's still an issue a year after surgery, then I guess we start radiation anyway. I guess that's my understanding. But I was just wondering if the situation, if anybody's experienced this same situation that I'm in, is this the best that it's going to be? And it seems like it continues to improve, but then for no apparent reason, I have a bad day with it.
Well, this has Dr. John's name written all over it.
Yeah, I was thinking the same thing.
I am going to pass this on, and then we have a couple of other people who also may have some input on this one. So let's start with Dr. John, and then he can choose who he wants to go to next.
There are some people who have not cleared up by 8 months and who do clear up by 12 months. So it's still possible to have more improvement, and this is why they don't really consider surgical interventions until a good 12 months have gone by. But a good way to really make sure that you've done everything possible is to have physical therapy. So you find a physical therapist that specializes in pelvic floor, and go through a course of physical therapy to make your chances as good as they possibly can be.
Right. I did that. I went to about a dozen sessions, and she said you've got enough to work with as far as exercises are concerned. Try it on your own, and then come back if you want. And I haven't gone back in I don't know, about 6 weeks now.
Are you still doing the exercises as you were when you were?
I am doing the exercises. Yes.
Oh, good. Then I really think that you're doing pretty much everything possible, and that you should give it more time.
Oh, okay. Yeah. All right.
And
so
it's kind of nice, and I mean, I don't know how long we can get away with this waiting on radiation therapy, but it's kind of nice in a way that you're not going to radiation therapy now because it would really maybe confuse things.
No.
Or even worsen things. So is your PSA good?
Yeah. My two oncologists have told me that because I'm tolerating the Orgovyx so well, that there's no hurry. 19 days into Orgovyx, my PSA went from 1.36 down to 0.08. And then a month later, it was 0.06. And I have a follow-up in 3 weeks for the next round of blood work.
Okay,
Yeah.
that's good.
So there was a study done quite some time ago. I'm sure we have it bookmarked somewhere. I know it's on Alan Adele's site, that says that there's no harm in waiting to start salvage therapy for 8 months. It doesn't really make a difference whether you start after 4 or you start after 8. So I think time is on your side here. And I've known plenty of guys who have had issues for up to a year. But just like Dr. John said, if it's still an issue at a year out, then maybe you have to think about other solutions. What are you thinking, Sam?
I did a year of Orgovyx and Erlita and had those same urinary frequency problems. It definitely improved as you went along. And in addition to exercises, I really virtually eliminated all bladder stimulants, alcohol, caffeine, and anything else, chocolate, and anything else that could stimulate or increase urinary frequency. And it got better. It really got much more tolerable.
Yeah. Those things are not an issue with me. I have eliminated caffeine, and I haven't drank alcohol in years. Those aren't. I don't know what else. I avoid sweets. I'm not guilty of any of those things. So. All right. The other thing is, I'm overdue for colonoscopy. So I have a consult set up for the end of July. I thought I'd use this window to get that done before starting any radiation. Seems to make common sense to do that. So,
Okay.
So that's all I have. Thanks so much.
Thank you. Anybody else have anything they'd like to contribute to this conversation about? John, is your hand up again?
Yeah, quick follow-up. Sam, that's a good point. I actually debated bringing that up while I was talking before, but we have to distinguish between frequency and, urgency and frequency on the one hand, and incontinence on the other hand. So if Tony's concern is incontinence, then it's good to avoid bladder stimulants, but it's not exactly to the point. But the frequency and urgency is so. I just wanted to make sure we were talking about incontinence versus frequency.
Like I said, I've gone many days where it seems to have normalized. There's
what seems to have normalized?
Well, urgency and frequency. Okay.
Okay. Then Sam's right on target. Yeah.
Right. So urgency and frequency have seemed to normalize. I don't have the urge to go to the bathroom for more frequently than every couple of hours or so. If I'm out walking my dog most of the time and feel like I have to go. You know, it's a little more than a mile walk, and I'm never, it never seems to be an emergency most of the time. Actually, all of the time. But then on the bad days, actually, the bad days aren't really bad days. It's just like bad incidents. For some reason, without warning, there's a leak, right? And that's why I feel like I'm, you know, not back to 100%. So
Tony, I know you're BRCA negative, but you had some gene testing ordered last month. Did you get any further
yes,
genetic information?
yes, actually, I got the results of that back. Yeah, thanks for bringing that up. I got the results of that back, and it came back with no risk factors, but it did come back with a variant of indeterminate consequence. So that was my results.
And that was a germline test, like the kind that they take from a cheek swab or a blood test, or was
it was blood test.
A blood test. Okay, thank you.
Yeah.
And what was the VUS, the variant of undetermined significance? What gene was that?
I don't know. I don't know. Don't think they told me that.
It'll be in the report.
Yeah. Okay. I don't have that in front of me. I can
Okay.
I'll bring it up next time.
Okay.
Yep.
We've got a couple of hands up. We got Dr. Pierre first of all.
I had a question in regards to the Kegels. Are they supposed to help incontinence in addition to frequency and urgency, or just incontinence?
Ooh, that's above my pay grade. We have to go to somebody who's a Kegel expert here.
There are also,
Jimmy.
there's, you know how there's stress incontinence and urgency incontinence. They have a little bit different definitions, but Kegels are used for those, as well as post-surgical incontinence.
You want to follow up, Pierre?
Oh, I'm just curious because, you know, we seem to be throwing everything into the same basket, and I have issues with urinary incontinence, but not frequency or dysuria. But, you know, it's improving with the exercise with the Kegels. I'm part of that PEP program out of Nova Scotia. So they basically change the exercise for pelvic strengthening on a weekly basis. It basically is gradient. And so far, you know, it's gradually improving. I'm let's see, December, January. I'm 5 months out from my prostatectomy, and when I saw the radiation oncologist, he basically said, you know, as long as you're improving, hold off on radiation. But at a year, you know, if things aren't where they need to be, he's going to recommend radiation no matter what.
And you're not at the is it Wilmot in Rochester as well, are you? Or is that where you're going, Pierre?
No, the one that I spoke to 2 radiation oncologists. The most recent one was at Roswell Park.
Okay.
And the previous one was at the Mayo. And
okay.
they both said, you know, don't be in a hurry to start radiation.
Right.
If your bladder's improving. On
Right.
a side note, you know, I've been on the Orgovyx and abiraterone since end of March, and my PSA is now undetectable, and my testosterone was down to 3.
Okay, which is great, which is exactly what we would want.
Right.
Exactly. How are you doing with that with the program from Canada?
I like it. I mean, it's a fair amount of effort. I mean, you're probably going to spend 25, 30 minutes every day if you're, you know, complying with the program. And then once a week, you send in a survey report, basically. But there's, you know, dietary instruction and that type of thing. They're strong advocates of veganism. For, you know, be it what it may, but yeah, I mean, I think it's worth the 6-month effort, is what it is.
Okay, well, it's great because we know we got a few guys signed up. We don't know exactly who, but we haven't heard a lot of feedback, so it's really, really good to be getting any feedback. Anybody else sign up for that program who's on the call today and wants to give us their 2 cents? I guess not, but Jeff Markey has 2 cents. Maybe even as a nickel for us. What's up?
Oh, I had no incontinence after surgery, but you know the doctors say wait a year, and I know a lot of people over at the Mayo Clinic have been getting theirs back after years. But I went 3.5 years and then had radiation, and I had no problem after that. But 6 years after that, I started having incontinence. And it's been 6 years since, and it's gotten worse and worse. And about 1.5 years ago, I went to a physical therapist who specializes in incontinence, and did those exercises for many months, and they didn't help at all. And on Thursday, I'm getting an AUS installed. I do take Myrobetric for urgency, because I used to wake up 3 or 4 times at night, and I thought I had to go, and I knew damn well I didn't have to go, but I still got up and went. And I don't get up, maybe once a month I have to get up in the middle of the night now. I make it through the morning. Myrobetric really works well for me. It doesn't work for everybody, but
Right.
But it doesn't, you know, it's supposed to help with the incontinence as well, but mine has just gotten worse over time. That's why I'm getting the AUS.
Okay, well, we have a couple of people with AUSs, and one of them has their hand up. So go ahead, the one with the hand up.
Sounds like me. Yeah, I'll just say that, you know, I tried mightily. I did not want to do any more surgery, obviously. The prostatectomy was quite enough, thank you. But nothing I did helped. And, you know, I work hard. I mean, you know, with all the humility I can muster, I put a lot of Kegels together. I put a lot of effort together. Didn't have a program, but I had a physical therapist for it. And I had to be honest with myself that I just wasn't making any progress. And my incontinence was always confined to the daytime. It was when I was up and around, sitting in a chair, walking around, especially walking or exercising, but really all day long. At night, totally dry. But it got to be so bad, and I finally got an AUS, and I tell you, I can't say enough good things about that. It's easy to use, it's pain-free completely. But surgery is a little bit, you know, it's a little bit of an ordeal, and you have to wait a couple weeks before you can use it. But after that, it's been nothing but a godsend. So I can only put in my 2 cents for how great it is. And if anybody who has heavy incontinence knows, and you're the only kind of person that can know just how hard it is to live with. Guys worry about their sexual function. We get old, we're having sex once in a while, but we're peeing all the time.
Yeah. Jimmy, is there, you know, any of the things that happened to you afterwards that might have been attributed to that AUS? Is there anything Jeff Markey should have a heads up about when they go to install it?
Man, I don't know. The only speculation, I had a lot of problems with intermittent high fevers and I had ended up with orchitis and epididymitis. Now I have chronic lymphedema. I think it was all because of radiation. I don't think it had anything to do with the AUS. I think radiation I think written when in your mailer, you said it's the gift that keeps on giving. And I don't have any doubt that, all the problems that I have that are long-term are all related to radiation. I was really hoping that I would put it off long enough that my incontinence would improve. I had to get the radiation, and they told me right away. They said, once you get the radiation, wherever you are with your continence, that's where you're going to stay. They flat out at least told me the truth on that. But I don't know. All I can say is, I look at what's in front of me, and what was in front of me was changing pads and towels in 15 days, and just being damp down there all the time and getting, rashes and stuff, and just it being just most unpleasant. You stink. I mean, I don't need to tell you, it was bad. So now it's not.
Okay. Anything to add, Dr. John? Any other heads ups for Jeff?
Yeah, I had a very, very high amount of pain for some weeks after that surgery. And I'm the exception. I talked to Jimmy a lot about this because he had his procedure just before mine. I got about a 75% improvement after it. I don't know why I had so much pain. Did my previous radiation set me up for all that pain? Was my surgeon careless? Really don't know. So just get a surgeon that's done a million of them and is extremely experienced.
My oncologist has told me the surgeon that's doing it is, and so many, she's fantastic. So
that's good.
I want to get the one that's done the most, but is not yet old.
And I never had problems at night. I don't have problems at night either. I don't sleep with anything on, and I never leak at night, unless I cough or sneeze.
Well, if the problem's not bad, do you want the surgery really?
If I am standing up, or I was working with a friend, helping him with the wiring for a stereo system. In an hour and 45 minutes, I totally soaked through a very thick pad. Yesterday, I had the same thing in a matter of 2 hours and that's just it. If I'm laying down, I don't have a problem. But if I'm sitting or standing or working, I can soak a pad up really quick.
Yeah, it's positional. I understand. Okay. Good luck.
You can't go anywhere. You can't do anything. I work a clamp, sure. The Wiser works great. Wear them for a couple of 2 hours, and you really have to take them off.
That really sucks. I'll tell you that.
Okay, well, we've given this issue a good airing, which we don't often do, and I'm really glad we have done, because it will also be helpful going forward to people who we can refer them back to this recording. So I think it's real important. We're going to move on to Barry B.
Hey, Rick, before you move on, Tony, I found this the report for the genetic testing.
Yes.
Yeah. Okay, so it says variant of unknown significance detected. It says SDHA, and then it has a code next to it. It says P.A148T.
Okay, well, I'm not even familiar with SDHA.
Not me.
And neither is Dr. John, but we'll look at it. So it's not one of the more common ones, but we'll find out. We'll find out if it has any significance. But we can't, there's nothing we can do with it anyway, because it's a VUS of unknown significance. Sometimes if it's a BRCA or an HRR or a Lynch syndrome thing, it makes us be a little more wary, but I don't know about SDHA. So anyone else other than John and me? Did anybody else have a SDHA or heard of it? Well, thanks, Tony.
Okay.
And you're not alone, man. See, look, Dr. Pierre's getting exactly the same advice you're getting, so that's a good thing. All right, Barry.
Good evening, gentlemen.
Good evening.
So just a little brief update from the last 2 weeks. First of all, I want to give credit to, and I forgot the name, but credit to the guy last week who mentioned that he was wearing one of those neck fans to
Yes.
deal with hot flashes and overheating.
Yeah, he's here again,
And,
Barry. Look, you see him at the bottom there, Bob Alvord? See him? He's wearing it again.
Awesome. Well, I bought one on Amazon with a long charge on it, and it was like 25 bucks, 30 bucks. I don't know what it was, but it's working like miracles. And related to that, you know, they had prescribed venlafaxine for me to deal with it. And so I promptly developed dry mouth, and then my tongue became sensitive to hot and cold. And so I quit the venlafaxine, I don't know, 10 days ago or whatever it was. And slow but sure, the dry mouth has been getting better every day. The tongue is getting better every day. And I love the fan. So I wear it outside working and everything else. At first I thought, oh man, this is going to be a hassle, and love the damn thing. So that's it.
Well, we're delighted to hear that. And to be honest, if we can do it without drugs, it's even better. And so, you know, the only thing maybe you and Bob ought to get him in multiple colors so they match your outfit. I mean, I don't know if that royal blue goes with everything there. But really, really pleased to hear that. We are somewhat obliged to remind you that if you do have adverse events from taking a drug, you should report them. So just saying, that's all I'm doing. I'm just saying. And, you know, it's interesting for me because I've been using venlafaxine for so many years, and it suits me down to the ground. But then, you know, other people take it and they have all these crummy events from taking it. So,
well, I'm going to try it as a weed killer.
It didn't work. It didn't work on me. So I'll just tell you, you know. What did you say? Dry mouth and what else?
Sensitive tongue.
Oh, that's right. Yes.
I couldn't eat an ice cream cone. I tried to eat an ice cream cone and it felt like it was burning my tongue off. Or if I drank hot coffee, it felt like it was burning my tongue off. And
oh my gosh.
Well, that stuff.
Look, we've got a lot of other different drugs, and you know, the drug of choice right now, which has its own side effects, including dry mouth, is oxybutynin. But if you're doing fine with that thing around your neck, whatever it is, are you wearing it right now? No, you're not wearing it. Oh, you're in your car.
I'm in my car. I'm just getting home, but I'll have it on shortly.
Okay. What color's yours?
Black.
Black, did you say?
Black, yeah, because I'm wearing it outside a lot too.
Oh.
I worked outside all day today, and I mean, I had to change clothes 3 times and take 2 showers to give you an idea of how hot it was out here working. And but I never felt overheated at all like I was before I put the fan on. And I mean, I had to quit before. I was just going to pass out.
Okay, well, all I can say is thank you, Bob Alvord. And I hope other gents get a benefit from this. All right.
Yeah. Thanks, Bob.
Okay.
Appreciate it.
Okay, we got a hand up. Who wants to talk to us about this? It is.
It's me.
Oh,
Dan
okay.
I have a question about the fan. Most of my hot flashes occur at night. Is it possible to sleep with one of those fans around your neck?
I'm going to find out tonight.
Bob Alvord, you've had it longer than anybody. Do you sleep with it around your neck?
I do not. Not when I go to bed, but I have it on all day. I'm not sure I could recommend it going to sleep because it can be kind of constricting in a way for sound sleeping.
I had another
But
question too.
Battery lasts 20 hours, so it'll last just great all day long.
Okay.
Is it about this topic?
Yes, he mentioned that he couldn't eat ice cream, and ice cream is a dairy product, so I thought we were supposed to stay away from dairy products because is that not true?
No, it's true, but everybody, sometimes you can do more damage than you can do good by staying away from what you like. We always tell people, if you're a meat eater, have a steak once a month and enjoy it. And if you like ice cream, have a bowl of ice cream once a week. But what you shouldn't be doing is having a big bowl of ice cream every night. Is that what you do? Do you have a big bowl of ice cream every night?
No.
No. Okay. And some of those soy products, I mean, I've found some of those soy products to be pretty good. The fake ice cream. So, Len, go on. What do you got on ice cream?
No, I'm lactose intolerant. I don't eat ice cream. But I wanted to mention to, or was it Tony? Who's in Schenectady?
Dan,
sorry. So, if you're in bed and that's when you're getting the hot flashes, you're relatively immobile. Just set up a fan on a desk. Bob Alvord does, he's moving around all the time, so you need it on your neck. But you just get a regular fan. Maybe a little desktop fan by your night table, something like that.
What I have is one of those portable handheld fans, and I just wake up, put it on high, let it cool off, put it down until I go back to sleep.
Good.
Okay, we're on a roll here. Jim Marshall, go ahead.
Yes, Dan. Anyway, I have about a 12-inch fan I happen to run throughout the night, pointed directly at my head. And I have it on winter, summer. It doesn't make any difference. And it really helps, I think.
Okay, how about you, Jeff Markey?
The one thing that the Ember Wave device did for me was stop my nightly hot flashes. It's got a night mode, and it really worked. It's got to be configured properly for night, but I used to wake up with my bed, the sheet wet under me, and it was miserable. And I still, last night I'm starting to feel a little hot once. I just put it on, slept the rest of the night without any problems. I don't know if you've tried the Wave device, but that's one thing.
Actually, I do have one, and I put it. I think it's on the 9-hour mode.
Yeah.
I put it in that, and it works sometimes, but sometimes it just doesn't.
Do you have it set to the coldest mode?
I do.
You're sure of that?
I'm positive of it.
Okay. Well, I guess yours are hotter than mine were at night. Have you tried oxybutynin? That's another drug that people here have said worked well for them.
Yeah, Yeah, I have a question for Jim Marshall. If I recall correctly, Jim, you've been on a drug holiday for years, right?
Well, actually, I just found out about 5 minutes ago. I have passed a drug holiday of 4 years now, and the PSA dropped from the last month of 0.11 down to 0.10. So
Well,
yes.
that's a statistical error, but anyway, that's really good.
Well, I don't care. It looks good anyway on the graph chart.
Okay,
So
my point is,
yes.
Why would you have hot flashes? You haven't been on any meds for years, 4 years.
Well, I don't have testosterone. It's extremely low, like anywhere from the 30s to the 40s. Actually, this one was 50. So,
okay.
I believe it's that. Occasionally, I will wake up all heated and stuff I have to throw off under the covers, essentially in the wintertime even, and cool down. Then I'm okay again.
Okay, we're moving along here, and the next person we're going to is RJ.
Hi there. So my question is around prednisone and abiraterone and aches and pains, because I finished up my chemo back in March, and when I was doing that, I was taking 10 milligrams of the prednisone, 5 in the morning and 5 in the afternoon. And so I stopped doing that. And then I was starting to exercise more. And then I started getting kind of like these aches and pains, which I just kind of chalk that up to, you know, going through a lot the last year. But then I pulled my back. I went running one day, and then I walked like 5 miles the next day, and I pulled a muscle in my back, and it was like that for, I don't know, like 6 weeks or so. And so, you know, a friend said, well, one thing is you might try, you know, like going back to doing that morning and afternoon for a couple days and see if that makes a difference. And it did. Like the general aches and pains sort of went away. And, you know, also my back was getting better, but now it doesn't hurt at all. And so I haven't done it for a couple days. I did it for like 3 days. And so my question was around, you know, because the reasoning that the friend had said that is because, well, like when you hurt your back, your body produces more cortisol, but your body won't do that. So like you don't have any kind of a natural response there. Have other people encountered that? And am I having like a weird reaction to the abiraterone? And, you know, is it a common thing to, you know, have, you know, more of the prednisone, or like how should I think about that? And, you know, that experience was good, but, you know, was that just something I can do in the future?
So RJ, I think there are two very separate issues here. The first is that when you take abiraterone, you need to take the prednisone because it prevents you from taking from making, I don't know what, cortisol or whatever else it does, but you've got to supplement it.
Yep.
Now, when you stop taking the abiraterone, you wean off the prednisone, so that you don't have adverse events. And it sounds like you did that just fine. So the abiraterone, the prednisone from the abiraterone, from all of that worked well. Then you had muscle aches and pains from exercising a lot. which happens because you've got to move back into that pretty gently. And you're finding that the prednisone is a good way to deal with those aches and pains, and it is a good way to deal with it, but it might not be recommended by your docs. And so that I'm setting the scene, and we've got 2 or 3 MDs in the group, and they're the ones who have to tell you, is this the way that you should be handling these pains? And since Dr. Pierre had his hand up, but he took it down, but then we're coming to you anyway, and then we'll check in with the other docs. So you kick this conversation a little further down the road, Dr. Pierre.
Yeah, no, normally in somebody who doesn't have cancer, with back spasms or whatever, we treat them, as long as their kidneys are okay, we treat them with non-steroidal anti-inflammatories, because they don't have the side effects of fluid retention, and you don't have to wean off of them. I mean, if you take prednisone for more than 10 to 14 days, then you can't quit it cold turkey, because your adrenals might be suppressed. And if you don't wean off it, you can crash. Basically, your blood pressure goes wacky and all sorts of side effects. So I guess if your kidneys are in good shape, I would treat you like I would treat a regular patient that has back spasms, basically, and try to stay away from prednisone.
Dr. John, anything to add to that?
So I think it's still a little mysterious. Maybe Len and Rick can help me about this. Whether a person taking Abby should be on 5 or 10 milligrams of prednisone if they're on prednisone. And I think it's a little tricky to know when somebody's having symptoms. When I was on abiraterone, I had a pretty terrible problem with blood pressure and swelling. So we just got rid of it. I was on 5 of prednisone. What if, I wonder, not that I wanted to stay on a drug that was harmful to me, but what if I was taking 10 milligrams prednisone instead of 5? Would I have tolerated the abiraterone better or not? So you're on 2.5 milligrams twice a day. Is that what you said, RJ?
No, it's just 5 in the morning.
It's just only 5 yeah. So, you got maybe, as Pierre says, it would be nice to avoid any kind of increase in steroids if you could use a non-steroidal to control back symptoms. But I always wonder in the back of my mind, and I think you need an endocrinologist to figure this out. And Pierre's got his hand up. Maybe he has an idea. Makes me wonder whether an increase might even be helpful. But I'd need a specialist to guide me on that. Pierre, could you follow up?
Yeah, actually, right from the get-go, they put me on 5 milligrams twice a day. So I'm on 10 milligrams with the abiraterone, and I've had no side effects from either one, other than hot flashes, obviously, which is as much from the Orgovyx as it is from abiraterone, probably. But I haven't had any fluid retention, and I mean, 10 milligrams is, I think, if I recall, pretty close to the physiologic dose. So maybe 5 milligrams is underdosing. I don't know.
Len, do you have any ideas?
Yes, I'm just looking at my notes from several years ago, where they ran a comparison between several doses of prednisone with abiraterone and with a dose of dexamethasone instead of the prednisone. And there's a lot of material here. I'm not going to read it now, but
The
bottom.
dexamethasone did well, didn't they, in that
Yes,
study?
yes, you
And the
remember
10
that.
milligram dose did well.
Yes, that's right. The 10 milligram dose of prednisone was the best prednisone dose, and the dexamethasone was better than everything. Dexamethasone had a few more side effects.
Okay.
That's the bottom line there. And I believe the clinical trial was run with 5 and 5 of prednisone.
Yes, that's correct. The clinical trial was run with 5 and 5, but then later on, after they introduced it, they found that maybe 5 was enough. And for some people, I think it was, and for others, it wasn't. So we've got the same two suspects again with their hands up. Jim Marshall first, and then Jeff Markey. Go ahead, Jim Marshall.
Yeah. Anyway, I started that back in August of 2017, right after the Latitude trial finished in June. Okay, and the recommendation then was to take 10. And then somewhere along the way, it was changed down to 5. So I think I was on 10 for about 2.5 close. I think about 2 years, and it was dropped down to 5. Okay, and I didn't really see a difference. Okay, in that time. So I don't know.
And Jeff Markey, and then I want to come back and sort of summarize a little bit for RJ. But Jeff Markey, you're up next.
I've got a couple of scenarios. There was one doctor who talked at one of the conferences that had prostate cancer. He was on 5 milligrams. He said he went to 7.5 because he had so much fatigue. And 7.5 worked great for him, except that it raised his A1C, his blood sugar, and he had to go back to 5. So that's something to watch out if you increase it. But I have a couple of guys I've worked with that just had terrible fatigue from 5 milligrams. And I had to move up to 10, and it helped a lot. And both doses are standard amount doses. Some doctors give 10 to start off with. But, you know, the low testosterone, it causes a lot of the joint problems. And I take 600 milligrams of gabapentin 3 times a day because of joint pain. And I've tapered off of it a couple of times, and both times joint pain came back. So I just stepped it back up. So it just, you know, that's the Orgovix alone or ADT alone can give you that joint pain. But Zytiga really lowers your testosterone even more, so it makes it worse. And I've never heard of prednisone helping with the joint pain. It helps with the fatigue. But you know, it may. I just that's the story.
Well, Dennis Carrere isn't here today, but he was on abiraterone for years, and he said the best thing about being on abiraterone was that he was taking the prednisone and he didn't have any pain, and it helped his golf game. So, you know, I do think that the prednisone can help you quite a bit if you have muscle issues, but I'm not a doc, but I come down on Dr. Pierre's side where if you can do it without using steroids, you're better off. RJ, what are you on any type of ADT at this moment or not? I can't remember.
Yes, Lupron. I go to Fred Hutch tomorrow. And so that's why I brought it up today, because I'm going to talk to the oncologist tomorrow and say, well, this is what's going on. And then this was it sounds like I'm not imagining things. But taking the prednisone comes with the cost, right? I mean, there's the A1C.
Yeah.
It's
I'd say something else. I mean, you know, you're off the Abbey. That's great. I'd try and get off the Lupron and get on to Orgovix. That definitely, especially for a younger man like you. I mean, that is, to me, would be a priority. And you may respond differently. We know that for some people, ADT I was going to say frequently, but fairly frequently causes muscle issues. It's not unusual at all. I don't know what the best, I mean, there may be some supplements that people can suggest, like Jeff just suggested for the muscle issues, and you can certainly talk to is it Schweitzer you see? I can't remember. No. Yeah, Schweitzer. So you can talk to Schweitzer about that, but get yourself off the Lupron and get on to org and stay on org, because when you do come off, you're gonna rectify much quicker. Len, and then we'll need to move on.
Yeah, this will be quick, Rick. I remembered that when people who were taking Abby plus prednisone and they didn't seem to be responding, they would switch them to dexamethasone, and about a third of those people would get some extra mileage out of the Abby.
Right.
So that's it.
Yeah, but this conversation really is more focused, I think, on what should RJ be doing about his muscle pain. It's not about the Abby, because he's off the Abby and he's okay off the Abby. He's not taking abiraterone anymore.
Oh,
so
I
really,
didn't know that.
So
I'm still taking the abiraterone. It's
you are still taking the abiraterone.
Yeah, I just finished the chemo, so they didn't actually tell me to bring down the dose, but I didn't have enough prednisone, and so I just assumed.
Oh, okay. I didn't understand that. So in other words, you're still taking the abiraterone, but you're not taking prednisone, or you're taking a lower dose.
But a lower dose, the 5 milligrams now.
Well, that's a whole different story. I thought you were talking about this with not taking the abiraterone. In that case, I stand corrected. I agree with Len. There's a couple of issues. One is maybe switch to Dex. How much Dex was it, Len?
Oh boy, I think it was 2.5 milligrams.
So, talk about, because I'm pretty sure Schweitzer will be familiar with the study.
Okay.
And if not, write to us and we can, isn't it in, it's written up on the blog, isn't it, Len?
Yeah, somewhere.
Okay.
Quite a few years ago.
It's a few years ago, but you can.
Then we can find.
If we had that, hey RJ, we had that search engine, we'd find it in a bloody minute, man. That was a low blow, wasn't it? Sorry about that.
Working on it.
We're working on it. So, yes, if that's the situation, and if you are more comfortable and you're having issues now, I definitely would think about going back to 5 and 5.
Okay, and I'll look into that dexamethasone too and bring that up with Schweitzer. Thank you.
Okay. And Org, bring that Orgovix up with him too. Get you off that Lupron. If it's gonna take a month to get the Orgovix, have him give you a 1 month shot based on getting the Orgovix over the next month. Okay, don't lock yourself into another 90 or 120 days. All right. Yes, I definitely think this is related. I was wondering why you stopped the Abby, but then I asked you and you said, no, you were just on the loop. Anyway, it's all good. We need to get you back to where you were, and then those muscle pains will go away. All right, who's next? Next on my list is Dr. Jack. You got 10 minutes, Dr. Jack. It's 6:17. I'm giving you a time. I'm giving you time today, okay?
Well, it's a lot of information, maybe more than you want to hear, because it's so complicated and so medically sophisticated. I'm not sure it's appropriate for me even to be talking about it. But I just got back from Innova. I saw Anna Barrick, handful of cardio-oncologists that have, some agency that's worthwhile. And she is terrific, no doubt about it. She ran something called a cardiac MRI, for flow, volume, function, very sophisticated test. And I'm sorry, somebody say something? Okay.
No, we're getting some feedback. I think it's from Dan. So I'm going to
and she read it with me since I'm a physician. She sat with me and we went over together. She was very enthusiastic about it and made me feel, oh my God, hopeful. She didn't see any scarring, any fibrosis, which I expected because my left atrium has gotten so drastically dilated over the years that, it's kind of scary. And my right atrium started to dilate also as a result of this doublet therapy, which started off, 3 years ago at 40, now it's 58. So it's gotten, pretty scary. So she said to me, well, that's a number, but you got to realize you don't have the fibrosis that goes with it. And then she gave me lots of hope that I'm not imminently on the verge of going into congestive heart failure, cardiac arrest related to an arrhythmia, fatal arrhythmia, all the other things that go with this kind of pathology. So I felt good about it. She said, come see me in 6 months and come on up again to Virginia. We'll do a repeat echo on you and I'll see, how you're doing. And as far as testosterone replacement is concerned, we talked about, she gave me some literature on it and said, it's worth an option. Talk about it with your medical oncologist, as far as possibly rebuilding some of the sarcopenic musculature in the atrium and the rest of the cardiac area because, it really thins out and it becomes very weakened over the years. And had I known anything about a cardio-oncologist when I first started, I would have loved to have utilized one, all along because it's very good to have one available to kind of coach you from the get-go. But that wasn't available. That wasn't an option back then when I first started this doublet therapy. And I think anybody who has an opportunity who's starting out with doublet therapy to see an oncologist and be coached throughout the whole process would really profit from it. And, something to consider were I to be starting right now. So what it turned out is that as I left and went home, I got the radiologic report. The radiologic report was not very optimistic. It did show the fibrosis in parts of that she wasn't able to read. She's not a radiologist. She's a medical oncologist, cardiologist, which is tough enough. To be a radiologist superimposed upon that would be, impossible. So I got to give her some slack. But she didn't do her report on the consultation, and I've been waiting for it. So what I did is I ran the radiologic report through Open Evidence, which is the ultimate medical large learning module that's being used for artificial intelligence, which is brilliant and has all the literature and everything on medicine. It scared the daylights out of me. And it told me I had the big triad that can result in sudden cardiac arrest, sudden cardiac death, which is I have the enhancement of the gadolinium. I have something called mitral annulus disjunction, which means the annulus around the mitral valve has dislodged itself, and I have arrhythmogenic mitral valve prolapse. That's a trilogy there that's frequently associated with sudden cardiac death. And I found it kind of scary, even though I'm 87. I don't want to die, but and I have had many friends go to sleep and not wake up. And so I just started to panic a little bit, and she still hasn't gotten back to me, but I went right into my, got to get a consultation quickly mode, because some of the therapeutics for it was I saw my electrophysiologist today, and I got an appointment to see Vivek Reddy in Mount Sinai, who's totally impossible to see, but he's squeezing me in for a telehealth to get the possibility of ablation done on the areas that are involved. And it's not pulse field ablation plus radio frequency ablation. And not only that, there's a sub epicardiac involvement. The epicardial part, which is very rare, the exterior part of the heart, and it goes through the chest and he's the only guy in the country who does this. Unfortunately, he's the guy who did my ablation in 2013. And if I need that procedure, he'd be willing to do it. It's risky, but he's the only competent person who can do it. So I'm kind of at a point that I'm kind of frightened, but I'm willing to go through it if that's what it takes. And I didn't expect any of this to happen. I have no cardiovascular history in my family at all, and I'm the first as a result of this wonderful treatment that we're all going through. And I understand. I see, John, in your list of problems that so many people in our group have cardiovascular problems, either secondary to or not the treatment that we've undergone. So I feel less alone when I hear that. But it's just terrible. Something has to be done. I only hope they find another way around treating us other than this doublet catastrophic modality. And maybe it's good for our cancer, no doubt, but it's horrible for our hearts. And so I've got a cardiomyopathy. It's a toxic metabolic cardiomyopathy. I'm going to go see someone by the name of Joshua Hare, who's the expert on cardiomyopathy in the country. He happens to be here in Miami, and he does stem cells and he does all kinds of other things, and he knows more about it than anybody. So I have nothing to lose by seeing him. And I got Reddy, the best man in the country who can do interventional work on my heart, and I'll see what develops. One thing I want to say before I stop is that don't trust your AliveCor, if you have one, on the back of your iPhone like I have, and don't trust your Apple device to check for atrial fibrillation. Very high incidence of false positives when you have lots of extrasystoles, skip beats, PVCs, PACs, whatever you have. If you have runs of them, it cannot distinguish between atrial fib and extra beats. And I was thinking I was in atrial fib, and I just had a lot of skip beats, and corroborated by the cardiograms up in Virginia, and today at my electrophysiologist said, you don't have atrial fib. And so I'm going to get a ZO patch, put it on, and I'll wear it, and we'll see if I do have any atrial fib. But when you get a lot of skip beats, it feels like atrial fib. You don't feel
Jack,
well.
So Jack, I want to go to Dr. John on this one, because he's been writing quite a bit about
I've been reading
and atrial fib and all the gizmos that you have and everything else. And between him and Jeff Markey, my eyes are Googled, and
I'll join them on Saturday.
Oh, okay. So go on, Dr. Jack. What do you got to? What are your words of wisdom for Dr. John? What are your words of wisdom for Dr. Jack?
Well, Jack is bringing in a lot of great information at a rapid pace. He is right on the last week. Our topic was atrial fibrillation. This week we moved on to different arrhythmias. But I appreciate the point about, we've talked a little bit about using smartwatches and handheld devices to tell when we're in atrial fib or not. We've talked a little bit about how to do it by taking your pulse. But here was a case where he had so many abnormal beats that it felt like atrial fibrillation, but actually wasn't. So always keep a little bit of doubt. Jack's going to come in on Saturday, I think, also. So
yeah, I'll be there.
We can have a good discussion. Jeff, I don't know if he's going to be there or not, but it'll be great to discuss further. But the stuff that Jack is getting from his cardio-oncologist, of course, is way past me as well. So appreciate hearing about it.
Also, my cardiologist.
Jeff, was that you?
What's on Saturday? I'm gonna have Dr. John give do a quick commercial break here for what's coming up on Saturday.
I have a heart group for people with prostate cancer and serious heart problems. It's been going on since the spring. And it's only been an email group, but I want to find out whether we should switch it to a group like this one where we meet face to face. So we're going to have a meeting on Saturday. The main purpose of the meeting is to find out whether a face-to-face meeting serves us better than our email group or not. We're going to impose on Rick and have it on his day off this week, but after that, we'll meet on a regular weekday so that we can keep AnCan from getting too far out of control, right, Rick? So, Jeff, yeah, if you can come, Jeff. Who else here is on my heart group? Jim Marshall is on my heart group.
What time
have you sent out a notice on ProsCard about this? No,
Yes.
I think yes.
Yeah,
it's
my
on your
last two Saturday every Saturday I send a mailing for this group, and on the last two I mentioned
you might want to send a special one around, and if there's anybody who isn't on the ProsCard group and has heart considerations, they are very, very welcome. Just reach out to me or Dr. John RD at AnCan or Dr. John at AnCan, and you're of course super welcome to attend. We've just focused this on the people that we know that are in the prostate cardio group, and we may have a couple of other people too. There's a care partner who has heart issues, and we've invited her, and anybody else. But if you have heart issues and you're not getting Dr. John's weekly email, then let us know. We'll put you on that list, and please come to the group.
Let me mention one relevant thing about testosterone. One of the therapeutic things that I'm approaching with my oncologist next week when I see him is utilization of low dosage, slow build-up testosterone, being willing to run the risk, because the competing for which I'm going to die from seems to be in the favor of cardiovascular. So I think I'll take the chances, because I have a very indolent, mind you, I had my reoccurrence 15 years after my surgery in 2003, biochemical, slow build-up, 5 years to find it, and I was treated so aggressively, insisting I have to go doublet when I wanted to go just radiation alone, SPRT, with a little bit of maybe 6 months, but 2 years, for an old guy like me, too much for the heart. And I think we have to learn some lessons here, Rick, for the people who are going to move forward.
Yeah, but I think I would say we are learning those lessons, and I point to some of the trials that are going on right now, like Lunar and Andromeda, and there are others as well where we are, and the long game that they're doing at NIH, where we are tying far more into your doubling time and how aggressive was your disease originally and what have you. Now, Robert wrote me about his study where they put him on 6 months, wasn't it? Apalutamide, Robert, 6 months apalutamide. And, why are we now saying, well, maybe that's too much? Now, that apalutamide, what was your trial called, Robert?
It was a Medicare trial. So it was Orgovyx, apalutamide, and spot radiation to the tumor.
And this was around a prostatectomy, correct?
I'd already had a prostatectomy and I'd already had salvage radiation.
Okay, all right. So this is a different trial, because there was a trial that reported today on apalutamide around a prostatectomy, which I think is a pretty. I don't like the way that trial was set up, but this is not. It wasn't your trial, and what I wrote back to Robert was, it really depends on your situation. If you had fairly aggressive situations starting like Robert did, I don't know that 6 months is enough. But if you had recurrence at a point in time where, like Jack or like my buddy Dave Fisher, who's been on here a couple of times, then yes, maybe you don't need hormone therapy. So there's no simple answer. I think what it takes is a sophisticated medical oncologist, not necessarily even a radiation oncologist, because they may not have enough knowledge, but a sophisticated medical oncologist who is willing to lay out the options for you. And for some of us, Jack for sure, he probably was a good candidate for the long game. You know, we would have sent him over to Modan at Dr. Modan at NCI, and he would have been a much happier camper today. I don't know if Dr. Modan would have been so happy, but Jack would have been.
Wrong place, wrong time. You know, mine was 3.5 years ago.
Yeah, we're
The
learning.
problem is we only know that in retrospect.
Yes.
About Jack.
Yeah, I know.
Right. So we can come back to this conversation, but I'd like to get through everybody. We only have two guys left. One is Eric C. and the other is Thomas. And so let's go to Eric C. first, and then we'll probably have some time left over and we can come back, because this is a great topic to unpack a little further if other people want to contribute. Eric in Hawaii.
Yeah, thank you for giving me time, gentlemen. I'm just went past my 2-year anniversary from starting on hormone therapy. I'm currently on Orgovix and apalutamide. I had been originally told that I was going to be over it after 24 months, and my doctors are saying, actually, that's not a good idea in my particular case. As I understand it, in this process, the disease is assessed, its virility is assessed, treatment is applied, and in the case of prostate cancer, I'm realizing that I actually am fortunate to have a castration-sensitive disease, so that this hormone therapy actually will work, and that given the specifics about my particular disease, that probably will not hold, and I will come to a time when I am castration resistant, and then I'm going to be entering a whole new phase. My question is, and I've talked to my doctor about this, and I've never really felt like getting the straight answers. Is there anything that I can do that can help me to maintain my castration sensitivity? I feel like just bulldozing along with the Orgovix, darolutamide are putting me at risk at some point of crossing over into castration resistance, and therefore making it a little bit more difficult in my treatment. Is that a fair assessment or what?
Who's telling you what doctor is it that's saying you need to do more than 24 months?
Good question. I have a team of doctors that are in San Francisco, as you're well aware, since we have mutual doctors in certain circumstances, but I also have a local oncologist here, which was originally required because I was on Eligard and I needed to have somebody local helping monitor that. I'm no longer on Eligard, but I'm continuing to see the local oncologist. Local oncologist, Dr. Brian Erickson, is the one who's saying, really, you should keep taking.
Right. So that's what I suspected. And the first thing I would do is discount that advice because it's not the current and the most recent thinking. And I think you've got to go back to, is it younger that you see it? Yeah. So you've got to go back to younger. You've got to see, well, Mac is not going to be available now for the next 3 months, but whoever's working with Mac, you should be talking to them. And I don't think you're getting good advice because the current thinking is probably less rather than more. And I can understand why somebody locally in Hawaii is saying, "Oh, you got to do more." They don't understand the disease.
So is it accurate then for me to have this understanding that just continuing to hit this disease with my current therapy will in effect speed up this period of time when I'm castration sensitive?
Yes.
And that it will cross over more quickly, effectively.
Yes. It's time probably now to go off to see how well did this work for you. There's a good paper that I'll try and put in that Kishan and Spratt just did recently, a meta study with 31 studies, and as they say, very few men need more than 18 months, probably not even 2 years, and you should give that study to Erickson and give him something to think about. But I would not be using him. This is why we really want you to have a good GUMO. A good GUMO might have pulled you off, or did you ever check with Roach whether he thought you should stay on for 18 or 24? He probably said 24, knowing Mac, but did you ever check with him?
Yeah, originally I did check with him, and yes, he did say 24.
Right.
But I've got to say that up front you develop expectations, right? And from my consultations with physicians that I thought knew their stuff and that I respected, there was a consensus. And now I get to the point of taking off. I was looking forward to for the vacation, and not happening.
Well, the thing is that the thinking is changing rapidly down to certain doctors, and Kishan and Spratt are amongst them because they're doing a lot of studies with how much radiation to give. And I think a lot of the GU medical oncologists are also moving to that less may be more. And there's no harm in, first of all, taking a break at this point in time and seeing how you do. Possibly just going on to darolutamide monotherapy, which a lot of our guys have done, like Len. He'll have something to say about that in a second. But after your treatment and 2 years of doublet, if it were me, I'd be asking to come off and do something different, whether that was monotherapy daro, whether that was a complete break. But I would really, really want to do something different. And the study that I'm just about to post into the website, which is the meta study I just mentioned, that was done in the context of ADT alone and not doublet. So it's not strictly true for you, but it's a good guide. Len, you want to say something about how long to do?
There it is.
Well, of course, everybody's different, so I hesitate to really comment here. I was diagnosed 12 years ago, Gleason 9, metastatic cancer. And I've spent less than half of that time actually on therapy. So more than half of that time I have been on a drug holiday. My cancer seems to be in a state of slumber, dormancy. Thank you. Okay, dormancy. But because it works for me doesn't mean it's going to work for anybody else. But here are the reasons why I always decided to take a drug holiday: to improve my muscular strength, cardiovascular health, bone health, and of course, I just plain felt better. So you have to weigh all those factors. I have two well-known, highly qualified oncologists. Both, when I asked them, do you think I'm doing as well as I am because I didn't stay on hormone therapy, they said no. There's no proof that intermittent versus continuous hormonal therapy is superior one to the other. I think that unless Rick is pointing to a new trial that I haven't seen yet, as far as I'm aware, all the data shows that those intermittent versus continuous therapy are non-inferior to each other. So they're equivalent. I don't know if that helps.
Well, they are equivalent, but they're not, because the quality of life is so much better on the intermittent, and we don't factor that into the trial results, which we should do.
So if they're comparable in terms of the outcome, medical outcome, I'd much rather be comfortable than uncomfortable.
Exactly.
I mean, hello.
Right.
Exactly.
So,
RJ, what do you want to say on this?
Yeah, I second and third all of that. And there's not a lot of empirical evidence. I mean, particularly like there's a conventional thinking that if you go on an intermittent therapy and you take a holiday, that your cancer is going to bloom and then you're going to become castration resistant all that sooner. There's no empirical evidence of that, and there's no empirical evidence that says there's anything that you can do that is going to prevent your cancer from becoming castrate resistant. It's evolution and it's mutations that happen, and cancer is a set of mutations, and it's going to go do its own thing. But what do you want to do? Like the medical oncologist that is giving you the treatment has said, I just want to keep giving you the treatment. And then you need to decide for yourself. It's like, well, do I want to get some of that testosterone back and just, at least, take a little bit of time to recover from this before you go back into that pool? That's my thinking.
Sam, what's your thinking?
Yeah, I've got a friend who has been on these Zoom calls in the past. He's a physician, and he has been on intermittent androgen deprivation therapy for 15 years, on and off and on and off, and he still shows no indication of being castration resistant. So, as the gentleman just said before, it's really the luck of the draw. It seems that way anyway. If you're castration sensitive, that's great. It may last a long time. It may not. We never know.
If it were me, I would definitely take the chance. I mean, I did 28 months, so you don't know, but I did do 28 months. And Mac wouldn't let me stop earlier, but I think today he might have let me stop a little earlier. We're going to take Dr. John, and then we're going to move on to Thomas Matika, and then I'll stay on as long as you like to come back to discuss any topics that we feel we didn't unpack enough. Dr. John.
My comment has to do with monitoring if you do go off. So it really doesn't need to be made now. We can wait a few months to talk about that.
Well, you had your hand up, so tell us. You whet our appetite. You can't do that.
All right. Well, it sounded like you wanted to move on. So what I was going to say is let's say you do go off. What are you going to do to monitor yourself? Well, the traditional thing is you're going to get quarterly PSA levels, and if the PSA is still undetectable, you're going to assume that you're fine. And to me, the debate is whether to add imaging to the monitoring. My oncologist doesn't think it's necessary. I think adding imaging once a year or something like that will add, because it's possible to recur without a PSA rise. You have a 1.0 decipher score and some Gleason grade 5 tissue. So I think if you do go off, just make sure the monitoring is really good. And then since you're still castrate sensitive, all you have to do is go back on the Orgavix and you'll probably get right back under control.
Yeah, well, those are my concerns, and I really appreciate everybody's input. Jim, you had another comment?
No, we're going to move now.
Yeah.
I know
Okay.
that Jeff G and Jim Marshall had their hands up, but we're happy to come back to this. But let's take Tom Matika first, and then we'll come back to it after the top of the hour.
All right. Thank you. Thank you very much.
Am I on?
Thomas.
Yeah. Well, this discussion here is extremely relevant to my question. I've been on Firmagon on ADT for going on 3 years, and on darolutamide standard treatment, 1,200 milligrams a day, for about 2 years. And along the way here, beginning of the year, came this the heart issues, and I had a diagnosis. I had a heart rate monitor, and it showed a 1% burden AFib. So it was a kind of a low burden AFib. Currently, I'm wearing a heart rate monitor again. I put it on a few days ago, and I'm going to keep it on for a month. They're taking a look at it again. But my concern, because of the heart issue, I kind of look back, because this heart issue, this arrhythmia, has been with me quite a long time, and with my sister too. So, maybe there's some genetic things in there, but it's been there for a long time. And when I get suspicious, I think, well, wait a minute. I started on this cancer treatment, and it seems to have accelerated. All of a sudden, I'm getting these, at first it was just an occasional occurrence of a, fast heartbeat and that sort of thing. And now it's happening, I don't know, every 2 or 3 times a week, 2 or 3 times a day. So I wanted I have an appointment with my oncologist on Thursday, and I want my request is to review my meds. And I'm thinking that these meds are I'm just going to say it. The meds are causing my AFib. The meds are causing this reaction, or exaggerating the reaction of my heart. So I'd like to cut down my darolutamide to half, go down to 300 milligrams a day. And I think whatever the half dosage is, but go down to half dosage there, and maybe switch to Orgavix. But that has some heart issues. So I guess I'm kind of trying to run away from the effects on my heart, because it's a pretty serious thing. It definitely affects me. I go to the gym. I went to the gym today. I didn't have a problem, but I'm really monitoring my heart, and I'm wearing this very professional sort of heart rate monitor. So the bottom line, should I try switching my dagarelix dosage? My darolutamide dosage, and let it go at that and see what happens? There's a lot of talk here about trying it. Okay, go off of it, see what happens.
Okay,
and
so in the interest of time, let's cut to the quick. What doctor is it that you're going to be seeing to review your medication?
Well, I want my regular oncologist to do it, Dr. Sokolova, but on
Okay,
Thursday,
so
I'm seeing,
Dr. Sokolova is on vacation, right? She's on maternity leave. So who are you seeing?
I think her name is Brett Bin or something. She's not an oncologist.
Okay, so cancel that appointment. I'm going to tell you what to do and you'll work it out and you'll get what you want, okay? Cancel that appointment and ask for an appointment with Dr. F. Stathiou as soon as possible and review your meds with Dr. F. Stathiou. And that's the answer. You know, I've said to all you guys who are in the Portland area, switch your care to Dr. F. Stathiou. Because there's been some issues. Now, Dr.
Are they going to let me do that? Are they going to let me do that?
I'm telling you, I am telling you how to go about this, Thomas. I wouldn't tell you if I didn't think they were going to let you.
Okay.
All right. We've had 3 or 4 guys switch already. Anybody on the call here right now?
Oh.
We have any other buttons? We've had people do it. I had somebody call me today and ask me how to do it. And now is the ideal time because Dr. Sokolova is away.
Yes.
All right. So I'll even give you the right telephone number because I was giving out the wrong telephone number. My bad. And so let me give you the right telephone number. Hold on.
Okay. 503.
It is 503-494-5058.
Okay.
And you call that number and tell them you want to make an appointment with Dr. F. Stathiou. Tell them you're an AnCan person. It won't mean anything to them, but they put it on the record. And once that gets to Dr. E's office, things go very quickly. All right?
And the reason is to review my meds. That's all I have to tell them.
All right. Well, I don't know who you're seeing right now. It's probably a nurse practitioner or somebody like that. I don't know. Then you say, I don't want to see a nurse practitioner. I want to see a medical oncologist, and I'd like to shift my care to Dr. F. Stathiou. I'm an AnCan person.
Okay. Okay.
All right.
I didn't know that you had actually done this already. That's fantastic news.
Oh, well, I've been telling you guys, and I've been putting it in the reminders. So, you know, it's nothing new. And we've had several people already who have seen David, you got your hand up. David D. Speak to me, David D. Speak to Thomas.
Dr. E had a wide open schedule when I went to schedule. I go from Seattle down there, and they were very accommodating. Her schedule was wide open. She's just opening that practice there. They were terrific to work with.
Fantastic. Very good news.
Okay. Now, you know, the other thing is that, again, I mean, who knows if you still need to be on, you may not need to be on treatment. You may be in a good place where you can take a break. And if anybody's going to give you a break, it's going to be Dr. Eleni. She's all favor in the breaks, and she's all about quality of life. And she can talk to you about you know whether it affected your heart or not, and you can bank on what she says. So I would say yes, you got all these issues. You probably need a switch in your treatment regime, and you got the very best person to design your new treatment regime.
Yeah, I thought she was out of the picture for me for some reason.
No, I don't know why.
I don't know why either.
She's happy to see our AnCan'ers. She likes our AnCan'ers.
Terrific. Fantastic.
Okay.
That's what I need to hear. Thank you very much. Thank you very much.
It's a pleasure. Now, it's almost the top of the hour. We have a few options here. We can the first thing I will do is anybody who arrived in late, because you came after the 5-minute witching hour, but you're got time before the top of the hour. If you came in late and you have a question, put your hand up right now. If there's nobody, and if you would like to, I'm getting some feedback from Jim Marshall, I think. So, yeah, we did that. There we go. If there's any topic that you want to come back to that you felt we didn't give enough time, now's the time to raise it. And I'll allow anybody in here to bring up something we didn't unpack enough.
What's the implication of doubling time, even in small amounts?
What's the implication for what? And Jeff G will come to you. I see your hand up.
Doubling time.
The doubling time is really, it's pretty significant. Have you watched our long game? Did you watch our long? Yeah.
Great
well,
stuff.
So again, watch that again, because they depend on the doubling time. If first of all, you've got to be somebody who makes PSA. So if you're Richard, if you're Foamy Gland Richard, it doesn't mean anything, because we know his PSA doesn't really make, his prostate cancer doesn't really make PSA. But if you are somebody who makes PSA, and you should pretty much know that from your diagnosis. I mean, if you were diagnosed originally with a PSA over about 7 or 8, and we got somebody's phone on here. Oh, it's Sam's.
Sorry.
Yeah, just so if you had a PSA that was, say, higher than 8, that's pretty normal, and it could have been 20 or 25, but we know you make PSA. If you're that sort of person and your doubling time has been really slow over your life, the life of your disease, then I think it does mean something. And this is what more and more medical oncologists are seeming to think, that, if you have a doubling time which is higher than 6 months, you're in pretty good shape to go somewhat easy on your treatment. If it's 3 to 6 months, maybe you need to go into treatment. If it's under 3 months, you got to go into treatment. So I would say it's more and more relevant as we learn more. That's what I would say. How about I want to make sure I get my hands right here. So if Eric Curtis do you want to say something about doubling time? Because I want to stick on this issue. Go ahead.
Right, exactly. And obviously, if you're very low figures, the doubling time can be, you don't have to rely on doubling time if your PSA is at 0.02 or 0.03 or 0.0. In my particular case, I've got doubling time. It's a short period of time, but it's from 0.03 to 0.07. That's machine error territory, so it doesn't matter.
Exactly.
It doesn't apply.
Yeah, thank you for pointing that out. If you Sam watched, then they said they don't take much notice of doubling time if you're less than 1.0, if you're under 1.0. So yes, it has to be significant. Anybody else want to say anything on doubling time to Sam? Okay, Jeffrey G, my Tucson buddy.
Thanks, Rick. What a great discussion about holidays. As you know, after 6 months of doublet therapy, I started a holiday 2 months ago and have been consistent with my PSA being less than 0.01. And I just wanted to comment on, of course, the benefits and the physical positive results I've had with my strength and, activities and well-being. But I also wanted to comment on the fact that 30 days in, my testosterone had continued to drop. Not a lot, but it's like, you know, turning a big ship. It seems to be turning pretty slowly. The only other comment would be that sorry, the hot flashes actually are still pretty strong and it feel as though they increased, as well as urgency. So that's really it. It's like the big ship. It just takes a while to get
Very much
through.
so. Yep, very.
But looking forward to the rest of this holiday, as long as God willing,
as
the
it lasts.
PSA stays down.
So there's a couple of things to point out. It can take a long time for your testosterone to come back, even though you're late 60s, early 70s. It can take a long time, and it may not, because again, everybody's different. We don't know, but it is like turning a big ship. And I mean, even me in my late 50s, when I came off the treatment, it took several months. It took six to 9 months for things to turn around. So it doesn't mean because you stop taking the medicine, things will turn around immediately. They don't. We want to get you onto Orgovix, because Orgovix, the ARSIs, they're, what do you call it? Remaining life. What's the phrase, Len? Or did Len leave? Len may have left. But the half-life of the ARSIs is relatively short, but the half-life of ADT is not that short. So, it just does take time, and you have to live with it. At the same time, you have immediate quality of life improvements. And this is what we were saying before, that yes, it may be non-inferior, the IHT, but it sure as heck is superior for quality of life when you're on IHT versus continuous. I bet the house on that one.
Very true.
So anybody else? Oh, wait, is Jack still with us, or did Jack leave? I think Jack left. I was going to ask Jack what he had to say to Thomas Matika, but Len is here.
Hello.
No, I thought you.
I had a backache. I had to lie down a minute.
Okay, I was trying to I was seeking for the phrase half-life, and then it came back to me. That's why I needed you. All right. Well, we're 5 minutes over. Oh, Jim Marshall. Yes, Jim Marshall. You wanted to say something before. Come on.
Yeah. Something about taking the holiday, and checking on it. I find, and it's only me, I still get whole test every month for now 9 years, because of the fact I want to believe that I'm staying on top of it. I do not want to wait 90 days, because after about 60 days, you start to think, well, what if? So as I said, the first of the month, I am there 8 o'clock in the morning to get my test. I always have them bright and early. Fasting blood test only. I don't care. It'll be a fasting, and also testosterone seems that the later in the day you get it, the higher it is. So as I said, anyway, 8 o'clock in the morning, and it stays consistently low.
Okay.
But that's just me.
Okay,
Thank
now.
you so much, Jim. That actually fits my situation. I am a monthly guy. Don't want to wait 3 months. So I appreciate that. Thank you.
Okay, now, Thomas Matika, you're still with us, aren't you? Right? I can see you there.
Affirmative.
You are affirmative. I'm going to give you another testament for switching to Dr. E. Luther, how long did it take you to switch to Dr. E once you made clear you were an AnCan person?
My appointment was 4 days later,
Oh, wow.
and it was great.
Hallelujah. Hallelujah.
She changed some stuff immediately.
Wow.
So
Well, I'm going. With that encouragement, I'm not going to take no for an answer. I don't care
There
what
you
they tell
go.
me.
There you go. All right, guys. I think this has been a great meeting. We had no newbies. We have plenty of time to talk about everything we needed to do. We had conversations. I loved it. It was great. Next week, Dr. John's in the hot seat, and we'll see you. It's going to be on the 9th. The 9th. Good night, everybody.
Nice job, Rick. Thank you.
Hey, Rick, good job.
Thanks, Rick. Bye.
Bye.
Everybody again. Thank you. Thank you.